Welcome to the Aural Apothecary podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, and Steve the chemist take on controversial stories, but we keep it edgy and light-hearted.
Podcasts share their desert island drugs and joyful patient stories.
Hi everyone, welcome to episode 4 of the Aural Apothecary. It just feels like an experiment. I hope you're all well. My name is Jamie Hayes. I'm a pharmacist and executive coach. As usual, I'm joined by my fellow apothecaries, STC in Bournemouth and Gimmo in Cardiff. In this episode of the Aural Apothecary, we will look at the use of nudging in changing the behaviour of clinicians. Joining us as our special guest is GP Dr. Lawrence Brad, and in the feature that has captured everyone's attention, Lawrence will share a desert island drug, a career anthem for the playlist, and a book for the Aural Apothecary Library. Before I welcome STC and Gimmo, just a quick thank you to you, our listeners. You were the early adopters and the innovators. Thank you for joining the conversation. It's been great to hear all your messages of support and how much you have enjoyed episodes 1, 2 and 3. Welcome STC and welcome Gimmo. Any news? What have you been up to since our last episode?
Thanks for that, Jamie. Good to be back. Well, you challenged me last episode to read the book that our last guest recommended, Amira, and I did. It's fantastic. For those who don't remember, it was Narconomics, and it was basically a précis about how the drug industry is pretty much run like any modern company, and I just thought it was great.
You mean the illicit drug industry, we should just say there,
yes.
for our lawyers.
Yes. The illicit drug industry. And what was interesting, as Amir was saying, was, funny enough, I've been doing my statin mandatory training, some of that this week, and listening to how one of the biggest challenges the drug companies have got is making sure that their staff are fully trained and they have their own version of statin man training in prison. So that caught my fancy.
Very good. STC?
Well, obviously we've been watching rugby and we've discovered that there isn't any limit to what you can do on Zoom. Is there, James?
There's not.
So Jamie and I and a couple of others ended up doing a virtual all-day session in Cardiff on Zoom for the rugby at the weekend, which was fun. Had to take a couple of hours off work, planned obviously. But yeah, I have done some serious stuff as well. In fact, our guest today, Lawrence Brad, and I were working on assessing some adverse events for a study at the University of Manchester, looking at the medicines discharge service. So that was quite interesting.
Yeah, and it's one of those when you're an Englishman living in Wales. It's one of those weekends that you dread. It's the double gloater, because obviously England lost when they probably should have won or could have won, and Wales won when they probably should have lost. So I've not really been grateful for lockdown that often, but not having to see my colleagues' gloating faces on a Monday morning, I was probably glad of lockdown this week.
So I've been piecing together a return to clinical practice.
It's a bit serious.
Yeah, a little bit serious. And, what's changed since I was last out and about? I suppose there's a few more anticoagulants out there than there was when I left. But we're still giving too many medicines to too many patients. That's my observation.
I'll second that motion.
Yeah, absolutely. So it's episode 4. How do you think it's going?
It's going, isn't it?
Well, we launched our social media this week. So we're recording a few episodes ahead of when you hear this. And so thank you to everyone who's followed us on social media. I think we've got about 127 followers and a bit of chat going. So I think Twitter's going to be the main place to go. But yeah, thank you to everyone who's followed us, and hope you enjoy the product when you finally get to listen to it. I think we actually go live for the first time tomorrow. We're all fingers crossed.
Good to go.
Okay, before I hand over to STC to introduce our special guest, just to let you know what we've got planned for you over the next few months. I'm delighted to say that we already have a waiting list of guests who have agreed to join us on the Aural Apothecary. As you will have realised by now, it is the guests that bring the class and culture to the show. So talking of which, time for STC to welcome this week's special guest.
So I'd like to welcome to the Aural Apothecary Dr. Lawrence Brad, GP down on the South Coast, who gave me my last job. And he is a fellow of the Royal College of GPs. He's a partner at the practice. He is also a clinical teaching fellow at the University of Bath, School of Pharmacy and Pharmacology, and part of the Wessex LMC, that's Local Medicines Committee, GP Education Programme leads. So he has a wealth of knowledge and worked as a GP for a long time. So welcome to the Aural Apothecary, Lawrence.
Thank you for inviting me.
Yes, so Lawrence, obviously you've been part of the stellar efforts around COVID vaccination in general practice, but what would you say was the number one thing on your agenda for the rest of, say, 2021?
Well, because I've got a bit of an education role, I think for me it's getting the balance right between helping everybody with their lifelong learning in the workplace and not actually triggering major burnout and stress in all the people I work with. So it's always been a bit of a challenge, but I think COVID is just like everything. It's sort of, accelerated the problems that we have. So we want to increase the adaptability and the resilience of our workforce, but at the same time, by doing that, I don't want to make them more stressed. And I think that's the thing that's going through my mind and my emails and my Zoom calls and coffee mornings every day.
Yeah, and I think that's the challenge. I've chatted over the last couple of weeks with a few people around. What's really worrying people is how do we re-enable services with a workforce that is potentially burnt out, lots of people suffering from stress, but at the same time a recognition that things are probably going to have to be different after COVID based on what we've learned. And so change is stressful in itself, isn't it? And on top of what people have experienced with COVID, it's going to be really difficult to do.
What practically, Lawrence, are you doing to keep yourself fit and healthy during this challenge?
Walking the dog, doing the rowing machine with some crazy stuff from Santa Monica on Apple Fitness, which I pinched from my daughter, which is good. And yeah, the occasional Joe Wicks, just like everybody else is doing, I think. And getting outdoors is the most important thing.
You're not doing Joe Wicks?
Occasionally. Does it not show?
No, I was just saying how embarrassing to say you're following Joe Wicks.
And obviously, like everybody, I got a new bike, which STC has seen because I cycled down to meet him one day. So I'm using a new bike.
A very nice bike it is too. You did tell me it was the only one left in the whole of the South region.
While we've got you on then, and you just mentioned the Apple side of life, any thoughts on, the wearable technology and the data that is about to sort of land in primary care, if it isn't already?
Well, my question I asked it when we had the last oximetry meeting for Wessex was, I said, does the Apple Watch count with the pulse oximeter on? But apparently they were very, very grumpy about it, all the ITU consultants. But I do think that's a really interesting thing because it's going to be a problem getting pulse oximeters out to all the patients. And, it seems to make sense if you've got your own monitor, whether it's one you've bought on Amazon or the watch, it just seems to me you can keep an eye on your normal physiological measurements. And I had a patient 2 days ago who said, totally of his own volition, he said there was the top 2 were sold out on Amazon of the oximeters. He'd got the third one, ordered it, and it was delivered the next day, and there he was doing his own readings. And I thought, it's amazing, really, isn't it?
It's the caveats, though, isn't it, Lawrence, to the technology? So literally today, chap telling me that he's got terrible atrial fibrillation, and he told me, it's all over the place on my pulse my pulse meter on my finger. He said it was 28 this morning, and I said to him, that's actually incompatible with life, and I'm going to suggest to you that you don't use that finger meter because of your irregular heartbeat. And he was a bit affronted, if I'm honest, but that just shows you, doesn't it?
Yeah, it's difficult.
Some of the discussions on the overdiagnosis group that I know Steve's a member of, they're very wary of it, aren't they, about the amount of data and, again, the caveats that Steve has mentioned coming their way, really. And so I think that is something for us to manage in the future. Welcome it, but with caution.
It's all about health-seeking behaviour, I think. There's some patients you can trust and it'll really actually help them, but there's others it's going to be very difficult.
But you can have all the technology you want, isn't it? But like you, Lawrence, the thing that keeps me going most, I think, in this whole situation is getting out and walking the dog, getting some fresh air.
Yeah.
Doesn't matter whether you've got your fancy Zwift machines, Jamie. Getting outside is what does it for me.
So, Lawrence, going back to your point then about what the challenges that lie for us in 2021, what do you think we can do as a small organisation that you and I work in to try and help all the, not just the clinicians, but the non-clinicians are feeling the stress as well, aren't they?
Yeah, I mean, I think the important thing is just to try and keep communicating with everybody, because I think it's so isolating when you're doing these Zoom calls. But, we've had this big debate about, do we keep our meetings? In the old days, you had all the people in the room and you had a meeting and there was a bit of lively discussion. And that's really, really difficult now. I think we have to just keep that conversation going so people feel they can talk about things. And that's the best we can do, really. It's this whole thing about just developing our capability. You need to help people cope with change. They need to keep their knowledge up to date. And all the time we're having to make everything more efficient. And that's what it's all about. And it's how you just do that without upsetting everybody.
Do you think the telephone triage model that we've moved to in general practice, although has been great for patients, has actually created another tranche of work that we've not quite worked out how to systemize it and work out what are the best people to deal with it?
Yeah, I think I feel much more for the more junior healthcare professionals, because I think when you're an old established GP and you kind of know your patients to a degree, I can get away with it much easier. We manage risk risk, as you know, all the time. And I think the more senior you are, it's okay. But I really worry for the med students coming through, the junior doctors, all our other allied prescribers. I think it'd be really tough being, living on the phone.
I mean, that's the expertise coming through there as well, isn't it, Lawrence? And, with your educational hat on and obviously a friend of clinical pharmacy and clinical pharmacists, what do you see as that relationship with the MDT, and how do we improve that over the next 5 years?
Well, as Steve knows, I think that the best thing about working with clinical pharmacists is, as I've said to him many times, it actually helps boost your confidence and lets you focus on the other stuff with the patients. Because if you know you've got a medicines expert in the building, it's very reassuring for all our co-workers to know there's somebody they can turn to. And it also just totally gives a whole different platform to our consultations, because if I know somebody's had a structured medication review with a medicines expert, when they walk in the room, I can think, fine, we can really actually talk about what your problem is. Whereas traditionally, of course, we're always trying to glance at the screen and the meds too.
So, I think that's a really important point there, isn't it? That having the pharmacist in the practice, it does all the medicine things, yet we know that, but actually improving the sort of team environment, even you're suggesting it improves the sort of well-being of individual team members within the practice. I think that's something that sometimes goes unnoticed, unsaid, especially during these times. It is so important, isn't it?
Well, isn't that what the evidence says when pharmacists were sort of doing this sort of thing in hospitals for the first time? That it improved the confidence of the prescribers that they were working with, and when this was happening 10, 15 years ago in hospital for the first time.
Possibly. I think I was probably working there then, and now that the fact is it's a smaller organisation, and this week I was presenting for a European conference coming up about my prescribing journey. For the last 20 years I've been a prescriber. One of the things I was talking about was it's so important to follow up the patients that you've seen to know whether or not your suggestion or prescribing advice was good or not. So I find myself now with Lawrence being able to discuss patients that clearly are outside my competence, but I've had them in a consultation. And then in the same way that he might want to come to me to ask about for my medicines expertise, of course, there's loads of things that I'm really barely competent at in relation to, diagnostics, for example. So it works in both directions. And I find it fantastic to work in such a great environment, because we also have paramedics, we have advanced nurse practitioners, we've got physician associates, physio practitioners. We've got it, haven't we? We've got everything. We've got the real proper team approach. And I think what you're saying, Lawrence, is that you value all of those people to help share the burden of the stresses of working with that amount of work.
Just to say, Steve, the unique thing I think about clinical pharmacists is they really have that expertise, whereas a lot of the others, it is a more general clinical input we're doing. There's something I think more powerful about pharmacists. And I'm not just saying that because I'm on this programme.
It's not a pharmacy programme, mind, Lawrence. So let me run this one past you then, Lawrence. So interprofessional learning in Cardiff Medical School and the School of Pharmacy and Pharmaceutical Science. In come the students, fourth year medics, fourth year pharmacists, third year pharmacists sometimes. We put them into threes to make sure that they're with two pharmacists and a medic, or a pharmacist and two, in a trio. And it's the most natural interaction that you would see, that we get them to introduce themselves and they start chatting, and the medical students immediately appreciate the skills of the pharmacy student and vice versa. As I say, it's the most, I do say to some of them, I said, if this interaction goes well, you may be finding a future wife or husband in the room today, if it goes that well. But then something happens. Then something happens in, foundation years, and that interaction between medics and pharmacists sometimes sort of goes off in a different direction. Any thoughts on how we can improve that?
I think it's different this generation, actually. I would hope that the younger ones coming through now, it's going to stick, it's going to be sustainable. I think the trouble is it all gets a bit muddied by all the historical things and our sort of past that we've had, where we were very siloed. And we've still got a big bit of work to do with community pharmacists, and it seems such a no-brainer to me that we should be working more closely, but my God, that seems difficult. But I do feel more optimistic about the future. But strangely, we teach the medical students from Southampton University, and that thing you were just describing, I think they struggled with it a bit between that interdisciplinary learning at undergraduate level. So it's probably credit to the way it's facilitated, and I think you've got to be quite smart about how you do the course to make that work at that stage.
Well, that's a credit to Professor John in Cardiff. It's been going 8-9 years now. Very impressive.
So, Lawrence, as you know, one of the benefits of coming on the Aural Apothecary is for you to have a cogitate in the weeks before to think about, and we'd like to ask you, what would you like to offer up as one of your desert island drugs?
Thank you. So, being good, I reached for the BNF, and it goes from abacavir to Zyvox. the A to Z. So I'm so glad I'm not a pharmacist, because you presumably know every single drug in the BNF. I don't know if you do answers on a postcard, but I had no clue what percentage of those drugs GPs prescribe out of the whole drugs in the BNF. So I'd love to hear that answer. Anyway, I got as far as it's a bit like that Blackadder episode where they try and write the first English dictionary and get stuck on aardvark. But it was easy, actually, because it's adrenaline is my drug that I would take.
For the obvious